Hi, everyone. Thank you so much for coming out in the rain and the cold. I was saying when I arrived, I left the house at 7 o'clock with just my shirt. And I was surprised to see I didn't really look at the weather forecast. So thank you very much for coming out. And thank you for Hope and Healing for hosting this event. I'm going to jump right in and share with you a sort of case vignette. Sarah is 15 years old. She's an adolescent who was admitted to an inpatient unit after she made a serious threat to kill herself. Sarah's parents got divorced when she was 4 years old, and she's been spending alternate weekends with her father. On the day she was admitted to hospital, Sarah's father brought her to the meeting point, a park, where he was going to drop off Sarah to be picked up by her mother. And when he began to leave, Sarah clung to him and started to cry. Sarah's had a tendency in the past to engage in dramatic displays to stop her parents or good friends from leaving her. This time, Sarah told her father that living with her mother had become unbearable and that if he did not stay with her, she would kill herself. During the past 2 years, she'd often threatened to kill herself. Her father tried to calm her, but she shouted that he was not hearing her, and she pulled up her skirt to reveal significant cuts and burns to her thighs. Her father was shocked. Since childhood, she's always been highly emotional and reactive, and he had become aware and concerned about alcohol intake and the fact that she was caught shoplifting a few times, but he had not been aware of any self-harm. She disclosed she had been cutting and burning herself for the last 2 years, and by this time Sarah was sobbing angrily and accusing her father of never being there for her and choosing a life with his new family instead of her. When her father tried to hold her to comfort her, she punched him in the face and started running away. When a car nearly ran her over, she collapsed and her father was able to catch up with her to take her to the hospital. On admission, Sarah appeared completely calm and said that she felt separated from her body, a feeling which she said she often has when she becomes stressed. She kept scratching herself and she did not want her mother to come to the hospital. So this was actually a case from the Menninger Clinic that we wrote up in a publication a couple of years ago. So if I were to ask you all whether you would diagnose a personality disorder in Sarah, if you were to see her. Now, of course, we don't diagnose off of one paragraph, but if you did meet Sarah, hands up, would you diagnose personality disorder? Okay. What about assessing for personality pathology? Would you assess? There's one in front, there's another nod. Anybody else who would be assessing for personality pathology? All right. So you guys are not alone. So this is a study that Drew Weston did in 2003. And he took some clinicians like yourselves and he asked them to pick out one adolescent patient from the last week that the clinician had been seeing for quite some time. And he asked the clinician whether they would be considering a diagnosis of personality disorder in this adolescent that they've been treating for quite some time. And you can see there that there's quite a varied and experienced group of clinicians that he asked, but only 28.4% of these teens that have been in therapy for quite some time with these clinicians received a personality disorder diagnosis from these clinicians. And the most common disorder was BPD. So since 2003, there's been this 5-fold increase in research on BPD in adolescence. We stopped our review here at 2013 when we published the book, BPD in Children and Adolescents. So there was this 5-fold increase since 2003 when Drew Weston did his study. So we would think that perhaps, given this increase in research in BPD, we would see a drop in the reluctance of personality, of clinicians diagnosing personality in young people. But this is a study done in 2013 in the Netherlands, 596 psychologists, again, sort of quite an experienced group of people, 27% in primary care, 58% in secondary care, 14% in psychiatric hospitals. Nearly 60% agreed that personality disorders can be diagnosed in adolescence. but only 8.7% reported that they diagnosed PDs, and only 6.5% offered specialized treatment. And here you can see the treatments that they provided: mentalization-based therapy, 25%, emotion regulation therapy, 17%, schema-focused, 12%, and DBT, 12%. So again, you see this pattern. 10 years after Drew Weston published his study and after this fivefold increase in borderline research, that clinicians are still reluctant to diagnose this disorder and then treat it. This was also found in a study in 2011 by Griffiths in England, where adolescent psychiatrists were interviewed. 82% accepted the overall BPD diagnosis for adults, but only 37% accepted it for adolescents, and 2% accepted it for children smaller than 12 or younger than 12. 23% used the diagnosis in regular clinical practice, and of those 23%, only 60% would actually feed back that diagnosis to young people. So even within those 20, there was 40% of clinicians who knew that the teen perhaps had BPD, but wouldn't feed back that diagnosis to the teen or the parents. And the qualitative feedback that they gave in the study, justifying their attitudes, was that the diagnosis can help families and young people understand their experience and difficulties. It may also help young people access appropriate interventions like DBT. On the other hand, the label may have stigmatizing, marginalizing, and objectifying effects on young people, making the diagnosis can lead to a worsening of the difficulties. The diagnosis leads to therapeutic pessimism and a belief that change is impossible because of this idea that BPD is intractable and untreatable. And the diagnosis is conceptually problematic, as it omits crucial developmental factors and makes assumptions about the enduring nature of personality variables, which is considered developmentally naive in adolescent populations. So they concluded in the study that the BPD diagnosis in adolescence is conceptually problematic, empirically insufficiently supported, and lacking in clinical utility. So here I list on the left-hand side the criteria for BPD. If we think back to Sarah, did you see evidence in that vignette of self-harm and suicide attempts? Yes. What about abandonment fears? Yes. Affective instability and reactivity? Yes. Impulsivity? Angry behavior? Dissociation? She felt like she was separated from her body. Relationship problems? Yes. We didn't really see evidence of emptiness or identity disturbance, but we did see evidence, if we go through those criteria, we did see evidence of BPD in this sort of short case vignette. And what Drew Weston did next in his study, he remembered 28% said that they would give a diagnosis of BPD in their teens that they've been seeing for some time. When Drew Weston actually then asked the clinicians to follow a list of symptoms like I just did with you, 75% of the patients met criteria for a personality disorder or for personality disorder symptoms. So there's something about actually assessing and in your own mind going through the criteria or the symptoms of BPD or personality disorder that actually may open up the possibility of diagnosing or considering the diagnosis. But this reluctance that you may be feeling and that people in the studies that have participated in these studies may have felt is really based on these biases or myths regarding the BPD diagnosis. The first one is psychiatric nomenclature does not allow for the diagnosis of BPD in adolescence. So thinking that the DSM and the ICD-11 prohibits the diagnosis of BPD. That certain features of BPD are normative. This idea that all adolescents are a little bit BPD-ish and they'll grow out of it. It's not really personal. My daughter is 11. She's turning 12 in January, and I'm just starting to experience the full impact of adolescence. The symptoms of BPD are better explained by traditional axis 1 disorders. So why do we need BPD? We can just explain this with anxiety and depression and ADHD. Externalizing problems, perhaps. Adolescent personalities are still developing and therefore too unstable to warrant a BPD diagnosis. So we can't really hang that diagnosis around someone's neck because the personality is still in flux. And it's going to stabilize and it's going to become more stable as the teen grows older. Perhaps PD is, because PD is long-lasting, treatment-resistant, and unpopular to treat, it would be stigmatizing. Actually, when you go back into the studies, many studies that have looked into this, it is this last one that clinicians feel strongest about, that it'd be stigmatizing to label someone with BPD. So what I'm going to attempt to do in the time that we've got left is really to debunk some of these myths. And if we have time, I will get to a little bit of what's the approach to treatment with this, but we may run out of time, so I'm going to see how we go. So first of all, psychiatric nomenclature does not allow for the diagnosis of BPD. Actually, the BPD diagnosis in adolescence has been allowed since DSM-3, so this is 1980s. Psychiatrists, psychologists have been allowed to diagnose BPD in adolescence, so it's never been prohibited. And also in the recent DSM-5, published in 2013, it is allowed. It's also allowed in the ICD-11, and both the ICD-11 and DSM-5 considers BPD and personality disorder as onset in adolescence. And I'm hoping that I can get to why that is later on, why it is true that the onset is in adolescence. BPD is also legitimized in the National Treatment Guidelines in the UK, the National Institute for Health and Care Excellence, the NICE guidelines, as well as in Australia. The US guidelines for personality disorder in general has not been updated since 2001. So it's not that, I think if they were to be updated by the APA, we would see the legitimization of BPD in adolescence in those guidelines. So what does the DSM tell us about BPD? So I don't know how many of you have kept up with the new DSM-5 formulations of personality disorder, but essentially there is now in the DSM-5 section 2, which is all the traditional ways of looking at personality disorder and all the other disorders. They're all listed in section 2 of the DSM-5. But then there is another section, a new section in the DSM, which never existed before, called section 3. Is anybody familiar with section 3? Anybody came across section 3 already? All right, so I'll stand still a little bit with section 3 as well. So section 2 retained the 10 disorders that you may be familiar with: paranoid, schizoid, schizotypal, antisocial, borderline, histrionic, narcissistic, avoidant, dependent. And borderline sort of falls into this cluster here, the cluster B, dramatic, emotional, and erratic. And that was retained in section 2 of the DSM. However, the DSM work group that was put together by the APA to review all the literature, do all the field trials for innovating and revising DSM criteria for personality disorder, they actually put forward an alternative model to this. And the reason they put forward an alternative model is because when you put all of the personality disorder symptoms across these 10 disorders into a factor analysis, you don't actually find these 10 disorders coming out. They're all comorbid with each other. All these symptoms are comorbid with each other. So in essence, this sort of borderline construct as defined in section 2 doesn't really exist in nature. And so what the alternative model that's in section 3 of the DSM-5 is promoting is this idea that there are 2 criteria that you diagnose for personality disorder. The first is what we call criterion A, and that is maladaptive self and interpersonal function. And maladaptive self and interpersonal function cuts across all of the personality disorder types. And so when you interview someone, you first determine whether they have problems in relating to others and whether they have problems in self-direction and identity. And when they have those issues, you say, well, they're in the domain of personality disorder, and they meet criteria for criterion A. Then you move on to criterion B, which are 5 maladaptive trait domains, which map onto the big 5 personality traits. And then you move on to the third component for personality disorder, which is you consider one of the types. So it's a more complicated model, but it captures something very important, which is that we can almost move away from these 10 types of disorders and just consider maladaptive self and interpersonal function. So if I have time, I'm going to come back to this, but I just wanted to, just because this is for CE credit, introduce section 3 to you. So when you do have time, I was on the ICD-11 work group, which completed its proposals that went in and is now being field tested. And it mirrors the ICD-11 conceptualization of personality disorders, mirrors the alternative model in section 3 of the DSM-5. This is not going to last much longer. So if you want to sort of be at the cutting edge of understanding personality pathology, we're moving away from this sort of structure of personality pathology. But here are the BPD criteria. Abandonment, we've gone through them when we reviewed Sarah's case, so I'm not going to stand still with them again. In terms of youth, the DSM section 2 are the same for adults and youth. When I started off with this research a little bit more than 10 years ago, I was fully prepared to say or conclude that BPD those 9 criteria are not downwardly extendable because I'm a developmental psychopathologist. It was, to my great surprise, over many, many studies, many, many samples, that we discovered that these 9 criteria are actually applicable to teenagers, not before 12, but 12 and up. And the DSM actually is in accordance with that. There's one exception, that criteria only have to be met for 1 year instead of 2 years, like in adults. And then there is a caution in the DSM section 2 that says it should be diagnosed only in those relatively unusual instances in which individuals' particular maladaptive personality traits appear to be pervasive, persistent, and unlikely to be limited to a particular developmental stage. So you're supposed to think developmentally when you assess a teen. Section 3 has no caution for diagnosing PD in adolescents. They say these traits should be relatively stable across time with onset that can be traced back to at least adolescence or early adulthood. And then, as I described, there's criterion A, severity of problems in identity, self-direction, empathy, and intimacy. They talk about it as the levels of personality function. They provide a scale in the DSM to assess for that. And then criterion B is the presence of 4 of 7 pathological personality traits: emotional lability, anxiousness, separation, insecurity, depressivity, impulsivity, risk-taking, hostility, of which at least 1 must be impulsivity, risk-taking, or hostility. And for that, they provide the PID-5, which you can download freely from the APA website to assess criterion B, so criterion A and criterion B. So using those 9 criteria, I've just listed here all of the validity studies and the measures that have been developed over the last 10 years to assess BPD in adolescents. And if you want the paper that this is based on, or that lays it out to you a bit more clearly, I'm very happy to send that if people contact me directly. But there's the CI-BPD, the child interview for BPD. There's the SWAP-A, the PAI-BOR, the BPFSC. It's the one we use typically, the BPFSP and the BPFSC-11. These are all measures that have been validated as adequate psychometric properties for assessing BPD in adolescents. The MSI-BPD, the BBQ, the Minnesota BPD scale, the DIPSI, which is a criterion B measure of personality pathology in even pre-adolescents, and then MMPI and the PID-5. That's been validated for adolescents as well. So this is just to say that those criteria that people have legitimized in these psychiatric nomenclature, there are multiple measures over the last 10 years that have been developed and validated to assess. If you are interested in some of these measures, write to me and I can send them to you. Many of them are for free. This is just an example of the BPFSC, the one that we use often. This is just some of the items. There's actually 24 items. This is the first 5. I'm a pretty happy person. I feel very lonely. I get upset when my parents or friends leave for a few days. I do things that other people consider wild or out of control. I feel pretty much the same way all the time. My feelings don't change very often. It's just to give you a flavor of the measure. And this is the sensitivity and specificity of it against clinician diagnosis as well as interview-based diagnosis. So we derived a clinical cutoff point that people can use. We then did item response theory analysis on a very large sample of about 6,000 teens, and we derived an 11-item measure off this 24-item measure, because even 24 items can take a long time in a clinical setting alongside a whole bunch of other measures that you might want to do for depression, anxiety, and so forth. But here you can see sort of the core features then of BPD as it continues to be validated in youth samples. I feel very lonely. I want to let some people know how much they've hurt me. My feelings are very strong. When I get mad, I get really, really mad. When I get happy, I get really, really happy. I feel that there's something important missing about me, but I don't know what it is. I'm careless with things that are important to me. People who are close to me have left me down. I go back and forth between different feelings, like being mad, sad, or happy. I get into trouble because I do things without thinking. I worry that people I care about will leave and not come back. How I feel about myself changes a lot. Lots of times my friends and I are really mean to each other, and the clinical cutoff is 34 on this measure. This is just an example of the CI-BPD. This is Mary Zanarini. She's at McLean and Harvard School of Medicine. She developed this measure off of the DIB-R, which is an interview-based measure for adults. This is just the first item. So you ask a teen, and we've done over 1,000 of these interviews with teenagers. In the last 2 years, have you felt very angry a lot of the time? If they do say yes, then you want frequency and intensity. You ask for an example, and then you want frequency and intensity. And it's a semi-structured interview. So you base each of the answers that you get. These are all sort of then additional prompts that you use to sort of finally assess in a semi-structured interview way. Do you see evidence of inappropriate, intense anger or difficulty controlling anger, frequent displays of temper, constant anger, definitely, probably present or absent? So we've done a lot of research with this measure. This is just one example where, again, we looked at where on the latent trait of BPD liability does this measure provide the most information, and it is at this sort of higher level of the latent trait. That's one way of determining whether the measure is supposed to be doing what it's done, but we've done quite a bit of external validity and criterion validity and so forth with this measure. So just a sort of snapshot of some of the research to support this idea that the psychiatric nomenclature does allow for the diagnosis of BPD in adolescents, and that there are multiple measures that have been developed and validated to assess for it in teens. What about this sort of second point? The certain features of BPD are normative and not particularly symptomatic. So this is the graph of the normative and normative course of maladaptive traits in people over the course of development. And you can see, as expected, it's true. All adolescents are a little bit borderline. So all of these maladaptive traits suddenly start going up here. But here you can see that there's a normative decline. Once the brain is fully matured, there begins to be a normative decline in these maladaptive traits of impulsivity, emotional reactivity, and so forth. However, several studies, this is the first study of 800 kids that were followed up from age 9 to 22, Patricia Cohen's study. There's about 20%, 21% of kids that don't follow the normative decline. Those are the kids that we are worried about for personality pathology. So they don't follow what we typically see for teenagers. This has been replicated many times. This is Barbara de Klerk's work in the Netherlands, where she again followed 477 kids. It's a 2-year follow-up, but she did very fancy statistics that helps her to unpack this from age 7 to age 17. And the spaghetti plots, you can see there's a downward trend, a normative decline, but there's also little lines that don't necessarily follow this normative decline. This was again replicated in a Pittsburgh study, 250 subjects that were followed up for 4 years. Both maladaptive trait approaches and BPD symptom approaches. And again, you can see those spaghetti plots. There's a lot of variation in kids, and not all of them follow this normative decline. And it's the kids that get stuck and that sort of plateau out in terms of these traits that we want to be able to capture, assess, and intervene with early. We want to intervene early because things are still quite plastic for them, and we can actually affect their trait development and trait consolidation and identity consolidation if we catch them early. So the summary, of course, then BPD onsets in adolescence. There's a general normative decline in personality pathology and an increase in adaptive personality traits. You may not know this, but as we get older, we become more agreeable, we become less neurotic, and sort of just we adapt better to society, but some people don't, right? Some people get stuck and they sort of continue to clash with their environment, struggle in interpersonal relationships, and don't find direction in life. So those criterion A issues. So some youth get stuck here. A subset of adolescents who diverge from the norm and whose personality pathology persists or increases into adulthood. The question then arises whether they meet threshold for DSM. And when we use all of those measures, the people that have used these measures to assess for BPD in all of these different samples find in outpatients an 11% prevalence for BPD, in inpatients 33%. Of inpatients will meet criteria. This is using interview-based validated measures for BPD, and in some samples, 43 to 49%. These are the kids in settings. We saw many of them in the Menninger Clinic who come to us at age 15. They've been in therapy since they were 7 or 8 for some internalizing or externalizing problems. They've had all of the diagnoses under the sun, and finally someone assesses them for personality pathology. Sometimes they're 22 when they get the diagnosis, and it's a huge, huge relief. I work very closely with the NEA BPD, who runs a family program called Family Connections, which is just wonderful to support family members of people with BPD. And again and again and again, the family members say, I wish I could get the diagnosis earlier. If we knew this was about identity and self-direction, intimacy and empathy, we could have address these issues earlier rather than give ADHD medication, rather than give bipolar medication, rather than treat the depression. Because all of those efforts led us nowhere until someone assessed for BPD and said, this is about personality function, this is about how you relate to yourself and others. Let's make that the target of treatment. We can call it what we want. We can call it personality disorder, we can call it whatever we want. But at the core of it, it is about how we relate, how we manage ourselves and how we relate to other people, the quality of our relationships. In epidemiological studies, so these are large-scale epidemiological studies in the UK, USA, and China, you can see these prevalence rates mirror adult prevalence rates. So here I was thinking that I would find a complete different picture in terms of epidemiology, correlates, phenomenology of BPD in teens. I'm a developmentalist, I was looking for it, and it mirrors adult BPD very, very closely, and there's good reasons for that I hope I can get into. This is just some from our data in the Menninger Clinic sample, and this is I just picked a few examples for you. This is 2 teenagers. One has BPD, one is a psychiatric control, so they have lots of other disorders, but they don't have BPD. So one kid says, do you feel angry a lot of time? All the time. I don't know how I just get mad or angry for no reason. I'll get angry once a week. What makes you mad? I don't know. I was in school because a teacher got me mad because he was being mean to the class for no reason. It got me mad. What do? I put my head down. I stay quiet or listen to music. Do you yell? No. Do you hit someone? No. One time when I scream, it was when they bug me. But other than that, I just leave everyone alone. What about in family? I leave family alone. When was the last time you needed to scream? Not sure. Has it happened a lot? More typical? Do you keep it inside? Yes. Do you think other people can tell? No. Why not? I don't show my emotions. I just hold on to them to act like everything is okay. How often do you hold it in? Like every week, not every day. Do you get so mad that you can't control it? No. You feel angry all the time? No, not really. These are CIBPD questions, so you can hear the prompts to try and get at that measure. On the other hand, we have a teen that says, yes, sometimes I hit my mom. I scream a lot, I go to my room, and it's just like I scratch myself with anger. I don't know, I do a lot of stupid stuff when I'm angry. I'm really impulsive. When was the last time this happened? It was in Miami a month ago, 2 months ago. What happened? She was trying to wake me up for school, and I was kind of sad. I didn't want to go to school, so she went to wake me up, and I just pushed her, and she fell on her butt. Which one do you think has BPD? the one on the right? So intensity disproportionate to the event. The teenager on the left feels angry too. They all do. My daughter, she went for her first sleepaway camp about a month ago, and she came back and she barely spoke with us for 2 days. And we realized we are now in the area of teenagers and we have to give her space. But it was so overwhelming, this whole situation, being away for the first time. She needed to just consolidate and needed space. But so they all go through a sort of a difficult period, but we can see the difference between a teen with BPD and not. Here's emptiness. I never thought, emptiness is so abstract. How can a 15 or a 13-year-old talk about emptiness? If they have BPD, they know what you mean. On the left-hand side, this teen says, it's an interesting question. I would say maybe no, definitely no feelings inside. I've had feelings here. Does it feel like there's a void inside? No, I've never been void of. The teen doesn't fully understand what we're saying. Is it nothing inside? I don't know. What does it mean? Like just empty? The teen doesn't get it, right? No, I haven't felt that. The teen with BPD says, there are things I feel should make me sad, and I don't cry about them, or I just think about them over and over again and analyze them and break them down into the tiniest possible pieces. And then I feel empty because I never actually absorb any of the emotion. This is a 15-year-old speaking. And then the things that used to make me happy don't make me happy, and even the things that make me sad don't bother me enough to make me cry anymore. So I don't feel like I have any emotional responses to things besides overanalyzing them. Like even when I'm happy, I don't feel like I'm ever in the moment when I'm feeling things what they really are. Like people are laughing, I'm laughing too, but I'm never really like I'm enjoying myself like a normally functioning person. So a disconnect between being in contact with her affect, essentially. And she can really talk about that very, very comprehensively. Identity disturbance, again, very, very abstract. I didn't think that we would be able to pick this up like we do in adults with BPD on the left. Someone says, well, everyone's different, but I don't know what you grew up with. Like your friends, they have taught you this, and that your parents taught you this. I don't know. I don't know which road to take. Should I be more like my friends? Should I do things like my friends, or should I be more like my parents? That's how I feel. And then the interviewer asks about going to college and career. No, I know what career. Okay, so you know that. I know I'm following that path, but I mean that over 2 years, it took me until now to college to find out what direction I'm heading to and what person I'm going to be in life. On the right-hand side, I feel like a bit like I have no identity sometimes, yes. I feel like I often, when I first meet people, I only act like a chunk of who I am. Like I don't know how to do it. And it becomes really confusing enough to really know which me is really me. Because I feel sometimes like a blank canvas, but sometimes I feel like a lot of times I find myself doing things with my actions or with my words, making so that it's not maybe what would be best for me, but more like what would be the most dramatic. So on the right-hand side, the teen has BPD. You can hear the left-hand side is struggling with identity, but it's cohesive and it's typical identity struggles and consolidating and working out who they are. They can articulate it. The teen on the left really feels that there's nothing there. It's like sand through her fingers. All right, so what we found in our research is that we do see that normative increase, but there's something qualitatively different. And it's got to do with how much sense the teen is able to make of what's going on with them. How much sense are they able to make of their traits, and how well can they integrate that and manage that in the context of everything that's happening with them in adolescence. What about this one? Symptoms are better explained by traditional axis 1 and 2. I'm going to throw some factor analysis at you again. This is when researchers take all of the symptoms of all of the disorders and they put them into a factor analysis. If a disorder exists, the disorder must come out in the structure of psychopathology. And so what you see here is the typical structure of psychopathology. We see internalizing and externalizing problems, depression and anxiety, PTSD, and so forth, conduct, substance use, and so forth. So symptoms load onto these two dimensions. What does borderline do? Borderline loads onto both internalizing and externalizing, but there's enough variance unexplained to justify its own disorder. So borderline is very much a confluence of internalizing. This is why it's so confusing. People see, and the typical trajectory that we've seen in the kids that we've treated are that they start off being quite anxious little ones. On the internalizing side, they struggle to manage it. It starts morphing into sort of oppositionality, not conduct disorder, but oppositionality. By the time they hit adolescence, if they didn't get the right scaffolding, that sort of confluence of internalizing and externalizing merges, morphs into criterion A dysfunction, maladaptive self and interpersonal function. Okay? So this is just another study with a bigger sample that showed the same thing. And this is in our kids. We actually replicated the exact adult findings again. All right, so not better explained by, it's a confluence of the two, but still a separate, there's something special in addition to it. What about personalities are still developing, therefore too unstable to warrant a PD diagnosis? Who's got children? Okay, so you know that when babies get born, they all have their little dispositional traits. You've got one child that gets born, and this child is open and approachable, and then you've got your shy baby who takes time to wait to warm up and is a little bit more reactive and requires a little bit more scaffolding from you. So babies come into the world with particular temperaments. Now, if we look at this, then we would say, well, personality traits aren't stable, right? If you look at the mean difference between this and that, you would say that's such a huge difference that we can't possibly say that traits are stable in adolescence. We need to wait until adulthood before we diagnose it, because look, it's unstable. However, what research has shown is that our position relative to our peers don't change. So while there's this sort of normative increase, everybody increases. And those that are more reactive remain more reactive than their peers. So it's relative. That's what rank order stability means. So there's actually very strong rank order stability, 40 to 65. One is perfect rank order stability. And it turns out that that rank order stability, your position relative to your peers in terms of personality disorder traits, is the same in early adolescence, middle adolescence, young adulthood, mid-adulthood, late adulthood. Doesn't change. Our position relative to our peers in terms of these maladaptive traits are the same. You always will be the one who's a little bit more reactive and a little bit more emotional compared to the people of your age group. So this idea that it's too unstable, it's as stable as it is in adulthood. There's lots more other rank order stability studies that sort of come out with the same coefficients, 63, 69, 53 to 73, also in clinical samples, 54. Very, very consistent finding across samples and countries. Similar rates with adults. All right. What about this last one? Because PD is long-lasting, treatment-resistant, and unpopular to treat, it would be stigmatizing to label people with this diagnosis. And so this is just a table that we produced in 2015. There's new studies after this of the treatment of the RCTs for, and non-RCTs, quasi-experimental studies for cognitive analytic therapy, CBT, DBT, 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 and then MBT, MBT, ERT, and ERT. So there is a growing evidence base for therapies for this group of teens who seem to be getting stuck. There are the same therapies that appear to work for adults. This is data from our Menninger sample where we showed, this is time 1 is baseline, discharge, 6 months, 12 months, 18 months. So these are teens that receive treatment, and you can see the parent report on BPD is in green. By the time they get to 6 months follow-up, they're below clinical cutoff. And by the time they actually discharge, according to child self-report on BPD, they are actually below clinical cutoff. Treatment works for these teens. It works for the adults. So that myth that this is an untreatable disorder, it's as treatable as depression. I would say anxiety is slightly easier treatable, except if it's a very severe sort of anxiety, but it's as treatable as depression. No, exactly the same effect sizes. this mirrors this sort of data, this data that we have in our adolescence mirrors Mary Zanarini. It's really Mary Zanarini who cracked this myth wide open that people with BPD don't get better. This is where she showed the rates of people. She followed them up over 10 years, how they are in remitted status, recovery from BPD, sustained remission, and remission from BPD. Most people get better if they get treatment. All right, so now I want to ask you, would you diagnose personality disorder in Sarah? You might consider it, perhaps I've moved you a little bit. Would you assess? And I would wager that if you assess, you would actually become more open to diagnosing it. The person who swayed me was Andrew Channon, and he wrote this paper in 2008 called BPD in Adolescence, the Diagnosis That Dare Not Speak Its Name. And I was, in the audience one day, and I was just saying, but we can't stigmatize teens by giving them this diagnosis. And then he said, Carla, you are the one perpetuating the stigma. If you don't call it by its name, and you don't call it out, and you don't say that this is just like depression, why is this anything different? It's got the same heritability coefficients, 50%. All psychiatric disorders are 50%. It's treatable. You can get better. It reacts to the environment like any other disorder. What's so special about it? I think sometimes people think it's special because we think about it as personality, who you are as a person, but personality is just self and interpersonal function. It's how we relate to other people, and that can become disordered. So now I want to talk just a little bit, so I hope I moved you on some of these biases. I want to talk about personality, or adolescence as a sensitive period for personality disorder. And so I already sort of introduced you to this idea of identity, self-direction, empathy, and intimacy as the core criterion A, cutting across all types of disorders. So really, I think going forward, before I die, we will just be using this, I bet. We will not really be thinking in terms of borderline anymore. We'll just be thinking in terms of the way people relate to each other, the way that they have formed and consolidated their identity, whether they've got self-direction and autonomy and agency, whether they are empathic and can think of things from other people's perspective and see other people's perspective, and whether they can have rewarding and satisfying interpersonal relationships. That is what personality disorder really is, and I think we will talk more and more as we go forward with changes in psychiatric nosology in this way about personality disorder. So this is the core of personality disorder. Turns out that BPD maps onto that very well. Of the 10 disorders, it's the only one that has these very clear self-other symptoms: abandonment, unstable, intense interpersonal relations, identity disturbance, chronic feelings of emptiness, paranoid ideation. Those are clearly self-other items. And even these more behavioral items, we know manifest in the context of interpersonal relationships. So even in DSM, old DSM, BPD represented what was core to, and I'm not going to go into a study that we did where we actually showed that of all the 10 disorders, it was only BPD that loads onto a sort of general factor of personality pathology. If you think about IQ as a general factor of intelligence, but then you can have verbal ability and spatial ability and so forth as sort of specific factors of intelligence, BPD maps onto general, so we call BPD the GPD, the general factor of personality pathology, because of these self-other, the core of personality pathology. This is then the ICD-11 criterion that also has now self and interpersonal dysfunction that I told you maps onto the alternative model of section 3 of the DSM-5. I won't go into the specifier there. So this is a reminder that there's kids that get stuck here, and we want to understand why that is. Why is it that adolescence seems to be a place? And those of you that have kids probably can already think where I'm going with this. But one thing I want to sort of emphasize first, let me go back here. There's something that happens here in adolescence that map onto criterion A for the first time. What I want to talk about before I reveal the secret is that their studies have shown that internalizing and externalizing, as I said before, precedes borderline. This is just a lot of studies that Stephanie Stepp reviewed. So, you know, you'll see internalizing and externalizing problems, internalizing and externalizing PTSD precedes depression, dissociation, then later BPD, substance use and internalizing, then later BPD, ADHD and ODD, then later BPD, experiential avoidance, then later BPD. And so we see this clear pattern of what I said before, internalizing and externalizing disorders sort of coming together, and then BPD emerging from that. But not the other way around. Studies that have looked at BPD traits, nobody would feel comfortable diagnosing personality disorder in an 8-year-old or in a 9-year-old. Why is that? Why is that? And so here is the model that we've put forward to explain that you have internalizing and externalizing disorders sort of pre-adolescence, and that this can be gendered, but we see a confluence of this in boys and girls, pre-adolescent, and then if there's no scaffolding for this, we see maladaptive self and interpersonal function develop here, criterion A dysfunction around adolescence. And this is the sort of severity. Some of you that keep up with the literature may have heard about the P factor. It's called the psychopathology factor. And that's just severity of psychiatric disorder. So as you move up the severity of psychiatric disorder, thought disorder and psychoticism is here at the top. So personality pathology lies somewhere here between what people used to, many years ago, call the neurotic disorders. Otto Kernberg used to talk about this in 1967. The neurotic disorders, and then he talked about borderline organization and the psychotic disorders. He was right. It took us 50 years with lots of empirical research to come back to this idea of psychopathology and the severity spectrum so the more you go up, the epidemiology, the percentage of people are smaller, the developmental onset gets later, and the persistence gets higher. But that's where personality pathology is located. Self-other, maladaptive self and interpersonal function. These are all the criterion B traits that may be observable. You can have little ones born reactive, and that the parents tell you they're reactive. You can have 2 kids who are same reactivity, but one has personality disorder and one doesn't have personality disorder. Why is that? That is because of criterion A, the story that adolescents begin to tell about themselves when they have the metacognitive capacity to do so. So what happens in adolescence? In Latin, it means to ripen or to grow up. 2 things happen. Self grows up. Identity development, Erickson has told us in the 1950s, it's a key developmental task. The agentic, self-determining author of the self begins to emerge. We begin to tell a story about who we are. In pre-adolescence, the organization and structure of the self is constrained by cognitive development. Preteens have a sense of, I run fast, I've got blue eyes, I've got long hair, but they're not putting it together in a coherent sense of self. So the move from self-concept in pre-adolescence to identity in adolescence necessitates meaning-making of self-concepts. We are active in that process. We are not passive recipients of our traits. We engage with our traits. We engage with who we are, and we get a lot of help doing that. Our parents help doing that. Our teachers help. Our peers in adolescence start giving us feedback, and we begin to construct a sense of self. It's an integration of autobiographical past with an imagined future in a coherent way. And the other thing that happens in adolescence, what grows up is our orientation to the other. Think about criterion A. Self grows up, orientation to the other grows up. So social reorientation takes place. There's a social awareness. There's an imaginary audience. There's shared reflection of peers that take place, shared reflection with parents. So there's suddenly multiple self-hypotheses that the teen has to integrate, and they have the metacognitive capacity to do so, but it's very hard work, and they need a lot of scaffolding from us to be successful in that. And it's very difficult scaffolding because you can't overstep your boundary, because then you lose them. Those of you with teens know that. So I don't know, you guys know this idea, but when you stand really close to the elephant and you look at the tusk, then it looks like a spear, and you look here and it looks like a snake. You think that the foot is a tree. When you stand really close to the elephant, you really can't see. That's how we sort of view pre-adolescents in terms of their personality function. Here I've just put the traits in: use people, crave attention, emotional. These are PIT 5 traits, criterion B traits. When you're a pre-adolescent, you may know that you're reckless at times. You may know that you're a bit of a worrier. You may know that you don't like being alone. But you haven't stepped away from the elephant in order to put that together in a coherent picture of who you are as a person. You have not started telling yourself a story that I am defective or I'm not defective as a person. That's what personality disorder ends up being. It is, what do I tell myself about how coherent can I talk about myself and keep the pieces of myself together while I'm in hot, emotionally charged interactions. That's what criterion A function really boils down to. So if we look through a developmental lens, the process of building one's personality does not come online in a mature form until adolescence, even though the structure, the traits may be there, the reactivity, the impulsivity, all of those things may be there. But we don't start the process of actively constructing ourself or our personality or identity until adolescence, because we don't have the cognitive capacity to hold everything in mind until adolescence. So criterion A function comes online then in adolescence. Criterion B function is there from the beginning. It's dispositional. We're born with certain traits. All right, just sort of, again, reminding you about how this fits visually. All right, so what are the treatment implications then? It means that criterion A is here, maladaptive self and interpersonal function. Here's the criterion B traits: negative affectivity, detachment, antagonism, disinhibition, or psychoticism. If we're going to treat criterion A, we'll treat the maladaptive interpersonal function, and that will have the knock-on effects on everything else that we want to treat. Our approach to doing this has been through mentalizing. I will introduce the concept of mentalizing. Who's heard about this before? I'll introduce the concept of mentalizing to you briefly. If we think about how can parents scaffold teens, it's going to be through mentalizing. Mentalizing is very important in infants. Parental mentalizing is very important in infants and preschoolers. We know that. That's the other big window for development of self and self-regulation and emotion regulation. The other new chance, the last chance that we have before the brain settles, is adolescence. So that if we do want to look at what can parents do to scaffold, it's going to have to be mentalizing. What can therapists do to scaffold? It's going to have to be mentalizing. I'm going to just introduce the concept.
Liberty.
You're gonna have a tea party with Play-Doh. I wanna serve myself. Here, Sarah. No!
Well, you've probably discovered that however smart your 3-year-old is, she doesn't seem able to put herself in someone else's mental shoes, to imagine how they think and what they believe. Perhaps you thought your parenting skills were to blame. But scientists suggest that understanding other minds is a skill that may not be fully developed until a child is about 4. To learn how children's social skills evolve between about 3 and 4, researchers use something called a false belief test. What do you think's in this box? Looks fairly obvious, doesn't it? Crayons. But let me show you. I filled it full of candles. All right, now I close it up again. While you and I have been having this conversation, Snoopy has been down here, asleep. Doesn't know what we've talked about. But let's bring him into the conversation. Now I have another question for you. What do you think Snoopy will say if I ask him what's in this box? Crayons, obviously. What else could anybody possibly say? Well, watch this 3-year-old.
What do you think is inside this box? Okay, let's open it up and see.
Candles.
Now, you can ask the child what appears to be a very simple question about that. What did you think was inside the box when you first saw it? They say, oh, I always thought that there were candles in this box. Then you can ask them about someone else. So you can ask them about Snoopy. Snoopy's been sitting here. He hasn't seen this box. He's never seen us open it up. What
What does Snoopy think is inside this box?
Candles.
Children say the same thing. Snoopy will think there are candles inside of this box. And what that indicates is that the children's view of how minds work is very, very different from the view that you and I would have.
Yes. Did you see it?
In the mind of the 3-year-old, everyone sees the world much the same way. There's no difference between what I think and believe and what everyone else, including Snoopy, thinks and believes. It is, in a sense, a naive and innocent view of the world, a kind of mental Eden. And then, about 4, comes the fall from grace.
Now, if you take a 4-year-old, quite typically the 4-year-old will tell you that, as a matter of fact, he thought there were crayons in the box, and then he found out that there were candles in the box. You can ask him about Snoopy, and he'll say, oh no, Snoopy will think that there are crayons in this box.
Great. Why will he think that?
Because it's a crayon box.
Mm-hmm. That's right. And that's going to make him think they're crayons. What's really in the box?
Candles.
Right.
And then you get the 5-year-olds who are just utterly blasé and think that this is such an obvious thing, it's silly even to ask the question. What that shows is that by the time children are 4 and 5, they have a view of the mind that looks much more like our view of the mind. They understand that things can be tricky and deceptive, that you can change your mind, that things aren't always the way that they seem. And that gives them a very different vision of how the mind works and how people work.
Remember, we're sharing this. Oh, I need that. Okay, then it's my turn.
Children who pass the false belief test now understand that other people can have different beliefs, even mistaken beliefs. Some scientists suggest that this test is further evidence of innate brain circuits specialized for reading other people's minds. They call it a theory of mind mechanism.
So that is theory of mind or mentalizing. It means the capacity to reflect on one's own thoughts and feelings and those of others to predict and understand behavior. Importantly, it means that people can change their minds. I can change my mind. Things are not always as they seem. Things are not always as I think they are. It promotes uncertainty and curiosity, seeks clarification, and it's a not knowing stance. So even though we all pass the false belief task when we're 4, what happens when you get home and you ask your husband to pick up the dry cleaning and he forgot? And he didn't, and you have to wear your little black dress to an evening event. In that moment, are you going to step back and think, oh, I wonder why, what might have happened that he forgot to pick up the dry cleaning? Perhaps I need to be curious and open to what happened and get his perspective on it. Or might you say, honestly, Harry, I've asked you many, many times before not to forget to pick up my... So you'll do the latter, right? And unless you can find your mentalizing you in that moment. So even though we all pass the false belief task, when we are high in arousal, sometimes our mentalizing shuts down. It's the prefrontal part of our brain, and we stop to mentalize. Turns out that borderline people often stop to mentalize and often think what's in their mind is in the mind of other people. Because I think it's so, it must be true. And they don't stop and wonder and think and be curious about what really happened here and how can I step back, how can I slow down and sort of trace back the steps. All right, so that is mentalizing in a nutshell. It's a form of imaginative mental activity, perceiving and interpreting human behavior in terms of intentional mental states. It underlies our relationships, the quality of our relationships, the ability to see other people's perspectives in relation to our own, what's in our own mind, and to hold on to what we are thinking, our values, what we are thinking, but balancing that with what other people are thinking. That is the sort of holy grail. So I'm going to just show you what we need to, how we then use mentalizing in relationships and why that's so important when we work with children and teenagers.
Science tells us that the experiences we have in the first years of our lives actually affect the physical architecture of the developing brain. This means that brains aren't just born, they're also built over time based on our experiences. Just as a house needs a sturdy foundation to support the walls and roof, A brain needs a good base to support all future development. Positive interactions between young children and their caregivers literally build the architecture of the developing brain. Building a sturdy foundation in the earliest years provides a good base for a lifetime of good mental function and better overall health. So just how is a solid brain foundation built and maintained in a developing child? One way is through what brain experts call serve and return interactions. Imagine a tennis match between a caregiver and a child, but instead of hitting a ball back and forth across a net, various forms of communication pass between the two. From eye contact to touch, from singing to simple games like peekaboo. These interactions, repeated throughout a young person's developing years, are the bricks that build a healthy foundation for all future development. But another kind of childhood experience shapes brain development too, and that's stress. Good kinds of stress, like meeting new people or studying for a test, are healthy for development because they prepare kids to cope with future challenges. Another kind of stress, called toxic stress, is bad for brain development. If a child is exposed to serious, ongoing hardships like abuse and neglect, and he has no other caregiver in his life to provide support, the basic structures of his developing brain may be damaged. Without a sturdy foundation to properly support future development, he is at risk for a lifetime of health problems, development issues, even addiction. It's possible to fix some of the damage of toxic stress later on, but it's easier, more effective, and less expensive to build solid brain architecture in the first place. One of the things that sturdy brain architecture supports is the development of basic emotional and social skills, an important group of skills which scientists call executive function and self-regulation can be thought of like air traffic control in the child's mental airspace. Think of a young child's brain as the control tower at a busy airport. All those planes landing and taking off and all of the support systems on the ground simultaneously demand the controller's attention to avoid a crash. It's the same with a young child learning to pay attention, plan ahead and remember, and follow lots of rules. Like all of us, kids have to react to things happening in the world around them, while also dealing with worries, temptations, and obligations on their minds. As these demands for attention pile up, air traffic control helps a child regulate the flow of information, prioritize tasks, and above all, find ways to manage stress and avoid mental collisions along the way. Having this ability is a necessity for positive and level mental health. Developing effective air traffic control, overcoming toxic stress, and building solid brain architecture are things kids can't do on their own. And since strong societies are made up of healthy, contributing individuals, it's up to us as a community to make sure all young people have the kinds of nurturing experiences they need for positive development. To build better futures, we need to build better brains.
So these same sort of scaffolding that's needed for early brain development, we have the same window again in adolescence for scaffolding the serve and return. So what we're trying to achieve in a sort of mentalization-based approach when we work with parents and with teenagers is we want to facilitate the literacy of interaction. So we put a lot of money into math literacy and reading literacy and nutrition literacy. We put almost no money into the literacy of interaction. And so we can argue, when I've started talking about this all over the world now, I also talk about how we have perhaps at a societal level, across different countries in the world, we've got a problem. We've become more illiterate in interaction. We can think about why that is. There's many challenges. Migration is one, the breakup of families. There is technology, of course. There's stress. We work a lot. We work more than what we've ever worked before. So we don't provide the laboratories for preschool children and for adolescents to practice and become literate in interaction. That's what the mentalizing approach tries to foster. Thank you.